بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد عليه أفضل الصلاة وأزكى التسليم. The title of our lecture today is Gastric Emptying. Starting with the motor activity of the stomach in response to the presence of food and food intake, the stomach usually produces the following types of motor activities. It produces receptive relaxation to allow the process of filling. Another type of relaxation known as adaptive relaxation allows the stomach to store the food and acts as a reservoir. Then the stomach is going to produce mixing of the contents after the relaxation and reserving or storing the food for about 30 minutes after the end of the meal. It's going to produce non-propulsive movement, which is called the mixing contraction, to help the mixing of the food with the gastric juice. And we have after that the propulsion and retropropulsion, which is progressive wave of relaxation followed by contraction to push the gastric contents forward into the antrum, and then there is something which is called the retropulsion that brings the food contents back to the body and fundus. And when the chyme or the food present in the stomach is turned into a fluid state, which is known as the chyme, the stomach is going to produce the emptying contractions or the process of gastric emptying. All these types of contraction is produced by the coordination of the autonomic nervous system, enteric nervous system, hormones, and the activity of the smooth muscles present in the wall of the stomach. These contractions usually appear in response to food intake. But during the interdigestive period, this means between meals, the stomach can produce or can show something called migrating motor complex, which is appearing in between meals to remove any remnant of food or debris of food or any secretions accumulated in the stomach. Also, we have another type of contraction which appear during hunger in response to hypoglycemia, known as the hunger contractions. Also, the stomach can produce emptying of its content toward the mouth as occur in vomiting. So we have different activity or different motor activity of the stomach, including the response to food, including the receptive relaxation. Then we have the adaptive relaxation, the mixing, then peristaltic contraction, and lastly emptying. All these are coordinated by the activity of the autonomic nervous system and the enteric nervous system. Also, the role of hormones and the smooth muscle in regulation of the smooth muscle of the stomach will be studied or will be needed to know during this lecture. Functional division of the stomach. The stomach is functionally or physiologically divided into proximal part and distal part. The proximal part, which is composed of the fundus and the proximal two-thirds of the body, characterized by thin muscle wall, so it is adapted or producing the reservoir function of the stomach. While the distal part, including the pyloric antrum, what is going to produce? This part is going to produce pumping of the gastric contents, so it is known as the gastric pump or the antral pump. The proximal part is characterized by its tonic activity, while the distal part characterized by its phasic activity. So again, we have proximal part of the stomach, which allows the stomach to act as a reservoir due to thin musculature in its wall, while the distal part provided with muscular or thick musculature, allowing this part of the stomach to produce pumping of the contents or emptying of the gastric contents into the duodenum. Now we are going to start with the first type of movements or motility present in the stomach, which is the receptive relaxation. The receptive relaxation is known as a vagally mediated reflex that is initiated or triggered by the peristaltic waves appeared in the pharynx and the esophagus. So, with the start of the pharyngeal and esophageal peristalsis during the process of swallowing, the vagus nerve will mediate or induce relaxation of the wall of the stomach, mainly in the fundus and the proximal two-thirds of the body. And this relaxation aimed to reduce the increase in the intragastric pressure, and this usually occurs due to the plasticity in the musculature, the plasticity of the smooth muscles present in the stomach to reduce the tension in the wall, and the second is the law of Laplace. With increasing the radius of the stomach, this will decrease the tension on the wall or reduce the tension on the wall. So the receptive relaxation appeared in response to the pharyngeal and esophageal peristalsis mediated by the vagus nerve, and its function is to reduce the increase in the intragastric pressure, as there is more increase in the radius, which will decrease the tension according to the law of Laplace. And the second is the plasticity, or the property of plasticity of the smooth muscles in the wall of the stomach. The plasticity means the smooth muscles is going to acquire new length, increase in the length without much increase in the tension. The second type of relaxation present in the stomach is known as the adaptive relaxation, and this usually appears when the bolus of food or food enters into the stomach. Entry of food into the stomach start or stimulate certain types of both mechanoreceptors and chemoreceptors, and these receptors are going to initiate either a local reflex within the enteric nervous system to produce relaxation of the wall of the body and the fundus, or another reflex that's go or mediated through the prevertebral ganglia of the sympathetic nervous system to induce the same relaxation, or another gastrogastric reflex or vagovagal reflex, means that the afferent and efferent in this reflex is mediated by both fibers of the vagus nerve, the afferent and efferent fibers of the vagus nerve. And the aim of these three reflexes is to relax the wall of the fundus and the body of the stomach, so the wall bulges progressively outward, increasing the capacity of the stomach to reach from 50 ml when it is empty to 1.5 liters when it is completely full. So this is going to increase the capacity of the stomach from about 50 ml during fasting to the maximum capacity, which is 1.5 liter with the complete fullness of the stomach. So we have adaptive relaxation, which appear when the food reach into the stomach, and the receptive relaxation appears with the start of the process of pharyngeal and esophageal peristalsis. So in order to reduce the tension in the stomach and allow the stomach to be relaxing and accept the food coming, there is the receptive relaxation, adaptive relaxation, as well as the feedback relaxation. As we mentioned, the receptive relaxation starts with the process of pharyngeal and esophageal peristalsis. Then the entry of food into the stomach will produce the adaptive relaxation, while the passage of nutrients into the duodenum, presence of excess carbohydrate and excess fat into the duodenum, will induce something which is called the feedback relaxation. These types of relaxation allow the stomach to dilate and accommodate the food contents or the food reached to it. And if we look to the chemical transmitter responsible or secreted or mediated by the vagus nerve to modulate the activity of the enteric nervous system, we will find that the neurotransmitter responsible for this is nitric oxide, VIB, and or ATP. That is the neurotransmitters released to produce relaxation of the muscle wall. Normally, the vagus excitatory fibers secretes acetylcholine and substance B in order to increase the tone of the smooth muscles or to reduce contraction of the smooth muscle. but during the process of relaxation or during the storage function of the stomach, the vagus nerve is going to release inhibitory neurotransmitter to induce relaxation of the smooth muscle. This include nitric oxide, vasoactive intestinal polypeptide, and or ATP. And as we mentioned, the volume of the empty stomach is about 50 ml and the pressure inside is about 5 millimeter mercury. The volume of the stomach with the three types of relaxation can increase to reach up to 1.5 liters, but there is a moderate or a minor change in the pressure. The pressure starts to increase when the volume inside the stomach exceeds 1.5 liter, and as we mentioned, due to the plasticity present in the smooth muscles and the law of Laplace. Law of Laplace means that there is an inverse relationship between the tension and radius. As we increase the tension of the hollow viscous, the tension as we increase the radius in the hollow viscous, this will be associated with the decrease in tension. Again, the mediators for the process of inhibition is the neurotransmitters secreted from the vagus nerve, including the nitric oxide, the vasoactive intestinal polypeptide, and adenosine triphosphate or ATP. The enteric nervous system and its role in the regulation of the gastric function or the gastric motility and secretion. As we mentioned previously, the enteric nervous system is formed of two types of plexuses. The first one is the submucosal plexus, and usually the submucosal plexus or the Meissner's plexus is controlling the secretions, controlling local absorption, blood flow, and the local contraction of the submucosal muscle. The second type of plexus is the myenteric plexus, located between the inner circular and outer longitudinal muscle layer of the gut. It controls the motor activity of the gut. For example, when the myenteric plexus is stimulated, this is associated with increase in the contraction or the tonic contraction of the gut wall, increasing the intensity of the rhythmic contractions, associated with increase in the rate of rhythmic contraction, and increase in the conduction velocity of the peristaltic waves. So, stimulation of the myenteric plexus is associated with increase in the tonic contraction, increase the intensity of rhythmic contraction, increase in the rate of the rhythmic contraction, as well as increasing the conduction velocity of the peristaltic waves. And if we look to the neurons of the myenteric plexus, the neurons of myenteric plexus are usually polarized or stimulated in two directions: oral direction and anal direction. Oral direction and anal direction. For example, distension of this part of the wall of the gut is going to stimulate the enteric nervous system, and enteric the stimulation of the myenteric plexus will produce what? Activation of the neurons before the bolus of the food by what? By releasing neurotransmitter like acetylcholine and substance B to induce contraction behind the bolus of the food. To induce contraction behind the bolus of the food. At the same time, this neurons is going to produce stimulation of another type of neurons which is present in the anal direction to release nitric oxide, to release vasoactive intestinal polypeptide and adenosine triphosphate in order to produce relaxation in front of the bolus of the food. Relaxation in front of the bolus of the food. So the peristaltic waves or the enteric nervous system is controlling the activity and has both types of excitatory neurons and inhibitory neurons. Excitatory neurons to produce contraction behind the bolus of the food and relaxation in front of the bolus of the food. Again, the myenteric plexus is polarized in two directions, either in anal direction by stimulatory neurons and in caudal or anal direction by inhibitory neurons to produce contraction behind the bolus and relaxation in front. As we mentioned, the second plexus is the submucosal plexus that control the gastrointestinal secretion, the local blood flow, local absorption, and the local contraction of the submucosal muscle. That is the enteric nervous system, which is considered as the peripheral, as a part of the peripheral nervous system, and it's composed of about 100 million neurons. Now we are going to have a beam of light on the electrical activity of the gastric smooth muscles. But before we introduce to the electrical activity of the gastric smooth muscles, we would like to have a focus or think about something which is called the interstitial cell of Kagel. Interstitial cell of Kagel is working as a connection between the enteric nervous system and the smooth muscles of the stomach. It is acts as a connection between the smooth muscles of the stomach and the enteric nervous system. These interstitial cells of Kagel are a specialized group of cells that more densely located in the corpus and antrum than in the fundus. Also, it is present in the intestinal wall. And as I mentioned, they are involved in the transmission of information from the enteric neurons to the smooth muscle cells. And as you know, the smooth muscles present in the gut is considered as a single unit smooth muscle fiber, and this single unit smooth muscle fiber allowing the smooth muscles to act as a one unit, or when they are going to contract, they are going to contract together. That means that the whole sheet of the smooth muscles is going to work together and contract together, and this is due to the presence of gap junction, And if we look to the interstitial cell of Kagel, these cells are considered as the pacemaker. The pacemaker. Why? Because they have the capacity to generate the basic electrical rhythm or the slow wave of depolarization that can occur spontaneously without the need of external stimuli. And as we mentioned, the resting membrane potential of the smooth muscle is ranging from minus 60 to minus 40 millivolt, and this usually produces the slow waves of depolarization. And when we have entry of calcium from the L-type calcium channel in response to stimulation of acetylcholine, this will produce the spike potential. Which will trigger the contraction of the smooth muscles. So again, the electrical activity of the smooth muscles is affected by the activity of the interstitial cell of Kagel. This interstitial cell of Kagel is known as the pacemaker cells that have the capacity to generate the basic electrical rhythm or the slow wave activity. Contraction of the smooth muscle occur when the slow wave of depolarization is converted into spike potential with the entry of calcium through the calcium channels or the L-type calcium channels. As we mentioned in the previous slide, the interstitial cell of Kagel is the pacemaker. They are generating the basal electrical rhythm or the slow wave of depolarization, conducting these slow waves to the smooth muscles through the gap junction. And when the smooth muscles are triggered by neurotransmitter or excitatory neurotransmitter like acetylcholine or hormones, there is increase in the calcium influx and calcium release from the sarcoplasmic reticulum, changing the slow wave of depolarization into spike potential, which is capable to produce the contraction of the smooth muscles. The generation of the spike potential as well as the contraction of the smooth muscle is regulated by the activity of the central nervous system, parasympathetic and sympathetic nervous system, and the enteric nervous system. Here we would like to give more detail about the resting membrane potential. The resting membrane potential of the smooth muscle is variable. It is ranging from minus 60 to minus 50 millivolt, and this is known as the resting membrane potential. The changes in the resting membrane potential which didn't reach to the firing level is known as the slow wave of depolarization. When the membrane potential reach to the firing level, which is minus 40 millivolt, this is enough to generate the spikes potential, and this spikes potential is composed of depolarization and repolarization. The depolarization and repolarization is known as the spikes of potential, which is caused by the process of sodium influx and potassium efflux. And if we look to the generation of the basal electrical rhythm, the mechanism of the generation of the basal electrical rhythm is mainly dependent on the interaction between the interstitial cells of Cajal with the smooth muscles. And as we mentioned, the interstitial cell of Cajal are known as the pacemaker, So we have slow wave potential known as basic electrical rhythm is called the bass setter potential. It is cyclic slow wave activity. These are going or not causing contraction of the gastric smooth muscles. The contraction occurs only with the generation of the spike potential. The base electrical rhythm rarely cause contraction. Spike potential on the top of the basal electrical rhythm is going to produce muscle contraction and increase in the muscle tension. This usually occur in response to stimuli like stretch, the neurotransmitter acetylcholine, and parasympathomimetics or the drugs that stimulate the muscarinic receptors. While the hyperpolarization or the inhibition of this basal electrical rhythm can occur under the effect of norepinephrine and sympathomimetics or the drug acting on the adrenergic receptors located on the smooth muscles. As we mentioned, this wave of depolarization is mainly generated from the interstitial cell of gel and then conducted to the smooth muscle through the gap junction. Most of the gastrointestinal contraction occurs rhythmically, and we will find this rhythm is variable. For example, in the duodenum it is 12 per minute, in jejunum it is 10 per minute, in the ileum it is about 8 per minute, while in the stomach usually ranging from 3 to 5 per minute. So these slow waves of contraction or this rhythmic contraction occurring in the stomach at a rate of about 3 to 5 per minute. And who is going to affect this? It is usually affected by the generation of the spikes potential from the slow waves of depolarization. After we studied the receptive relaxation and adaptive relaxation of the stomach to produce the storage and reservoir function of food after meals, and studied the mechanism of generation of the spike potential from the basal electrical rhythm. Now we are going to look for the mechanism of mixing. The mixing function of the stomach is produced by three movements including propulsion, grinding, and retropulsion. Propulsion, grinding, and retropulsion. The transport of chyme from the gastric reservoir into the antral pump is caused by two mechanisms. The first one is the tonic contraction of the proximal stomach, and the peristaltic waves from the fundus to the pylorus. So we have tonic contraction coming from the proximal stomach, and we have the peristaltic waves from the fundus to the pylorus. We will start with the propulsion, and the propulsion is considered as a weak peristaltic waves, and these are constrictor waves that constricts the stomach and its contents 3 per minute or 1 every 20 seconds, and this usually initiated by the basal electrical rhythm. So propulsion means we are going to push the contents forward, and this usually is a constrictor peristaltic waves coming from the fundus towards the pylorus, and this usually occur at a rate of 3 per minute. Then the second function is known as the grinding, and it is considered as a vigorous peristalsis, as the wave of propulsion of peristalsis moves down into the distal part of the stomach. Its force or its amplitude is going to increase, and when the amplitude or force is going to increase, this produces grinding of the gastric contents. Lastly is the retropulsion. And the retropulsion is a forceful contraction of the pylorus, to push the gastric contents or push the chyme back towards the fundus, and then the wave will start again with propulsion and grinding and retropulsion. These three movements allow the mixing of the gastric contents with the gastric juice and also produce softening of the gastric contents, allowing the chyme of hard food to be softened, and this will prepare for the next movement, which is the emptying of the gastric contents, So we have a constrictor wave starting from the body at a rate of 3 per minute, and this is going to increase in intensity to produce the grinding, and once the chyme reach to the pylorus, there is a retropulsion to bring the contents back to the stomach in order to produce mixing of the gastric contents and softening of the gastric contents. Now we are moving to gastric emptying. The process of gastric emptying dependent on the presence of two types of contraction. Number one, tonic contraction and recurrent corpus antral peristaltic waves. The tonic contraction, usually caused by hormones or by continuous entry of calcium into the smooth muscles, that will lead to the formation of continuous spike potential. This continuous spike potential will produce tonic contraction of the fundus, At the same time, there is recurrent corpus antral peristaltic waves, and this usually makes the chyme to grind or grinding the chyme into 1 to 2 millimeter solid particles suspended in the gastric juice. So the recurrent corpus antral peristalsis wave makes grinding of the gastric contents into 1 to 2 millimeter solid particles suspended in the gastric juice. And as we mentioned previously, the slow wave of peristaltic waves, the slow frequency of the peristaltic wave in the stomach, which is about 3 times per minute, is going to allow the stomach to empty at every time about 2 to 4 ml of the chyme through the pylorus into the duodenal bulb. So usually these slow peristaltic waves allow the gastric contents to be emptied into the duodenum at a rate of about 2 to 4 ml per contraction. We have also something which is called the antropyloroduodenal coordination. This antropyloroduodenal coordination refers to the efficient bumping or the efficient emptying of the chyme through the pylorus into the duodenum, and this usually affected by the change in the sphincter tone. Also, the duodenal contraction representing a resistance against the process of emptying. So, the antropyloroduodenal coordination is the process by which we coordinate or makes controlling or regulating the process of emptying through the contraction and relaxation of the sphincter, as well as the duodenal peristalsis or the duodenal contraction. Now we are moving to the factors affecting the gastric emptying. The factors affecting the gastric emptying include factors related to the food. Number two, we have gastric factors and duodenal factors. Type of food. Carbohydrates leave the stomach in a few hours, while proteins leave more slowly, and the fat are the slowest to be emptied. So according to the nature of the meal or the contents present in food, as the food or the meal containing more carbohydrate, its emptying will be faster than if it contains fat and protein. Second is the gastric factors. Gastric factor, the degree of gastric distension. Within limits, the greater the distension of the stomach, the more rapid will be the rate of emptying. The distension of the stomach will initiate the vagovagal reflex and the local enteric reflexes to stimulate the gastric peristalsis and accelerate gastric emptying. Number two, related to the stomach, is the consistency of the gastric content. As the food is more soft or the chyme is more soft in the stomach, this will accelerate its emptying, while the presence of solid food will delay the process of gastric emptying. So, according to the type of food or according to the gastric factor, type of food, carbohydrates is emptied faster than fat and protein, and that's why usually the food that contains or the meals that contains protein and fat gives satiety for a long time because it takes much time to be emptied from the stomach. Then we have the gastric factor. Increasing the gastric distension will increase the gastric emptying. The more soft of the food, the more the gastric emptying. Now we are moving to the duodenal factors affecting the gastric emptying. Number one, the degree of duodenal distension. Excessive distension of the duodenum produce initiation of the enterogastric reflexes that inhibit the gastric emptying. The excessive distension of the duodenum initiate enterogastric reflexes, and the enterogastric reflexes inhibits the gastric emptying. Type of food in the duodenum. The presence of excess fat in the duodenum is going to delay the gastric emptying through the release of the enterogastrones. The enterogastrones are the hormones that's going to produce inhibition of the gastric contraction and the gastric emptying. Since this effect is important, since fat are much slowly digested than other kinds of food, the presence of excess fat in the duodenum will delay the gastric emptying, allowing the duodenum to take more time and the bile to be secreted from the liver to facilitate the digestion of fat. Duodenal acidity. The presence of excess acid in the duodenum will produce the delay in the gastric emptying, and the mechanism is dependent on both the enterogastric reflex and enterogastrones. Lastly, the presence of hypertonic fluid or hyperosmolarity of the duodenum will delay the gastric contents, delay the gastric emptying, or delay the gastric emptying contents into the duodenum. Other factors: stimulation of pain receptor produce reflex inhibition of the gastric emptying. Emotional state, excitement and anxiety and anger accelerates gastric emptying, while fear slows it. So the emotional state can affect the gastric emptying. Chemical factors like the parasympathomimic drugs or cholinergic drugs, coffee, alcohol, bicarbonate, all these factors accelerates the gastric emptying, accelerates the gastric emptying. Now, after we finish the mechanism of gastric emptying and the factors affecting it, we are going to another type of contraction which appears during hunger, which is the hunger contraction. In response to hypoglycemia and decrease in the blood sugar, which usually occurs 12 to 24 hours after the last meal, this hypoglycemia is usually stimulates certain types of glucoreceptors located in the hypothalamus, and when the hypothalamus is stimulated, it's going to stimulate the vagal nucleus in the medulla oblongata. Stimulation of the vagal nucleus in the medulla oblongata will send the vagal nerve to increase the contraction of the stomach, or to induce contraction of the stomach to produce the hunger contractions. So hunger contractions are caused by hypoglycemia stimulating the glucoreceptors of the hypothalamus, which will stimulate the vagus nerve to induce this muscle contraction. These hunger contractions are rhythmic peristaltic contraction that occurring in the body of the stomach, and usually occurs when the stomach is empty, and as I mentioned, after 12 to 24 hours after the last meal. Sometimes, or in a certain situation, these contractions may fuse together, causing high tetanic contraction that may last for 2 to 3 minutes. Usually it short time, it takes about few seconds and disappear, but it may fuse to form high tetanic contractions that last for 2 to 3 minutes. Such pain, as I mentioned, usually appear 12 to 24 hours, okay, and sometimes they become painful and named as hunger pangs. They are named, when it is painful, named as hunger pangs. In case of starvation or absence of food, the hunger contraction reach to its maximum or peak 3 to 4 days, then they gradually weaken in the succeeding days. Hunger is felt as a result of stimulation of the feeding center located in the lateral hypothalamic nucleus, while the hunger pangs or the hunger contraction is not related to the hunger sensation. The hunger sensation is felt at the level of the hypothalamus. The hunger pangs is due to the hypoglycemia that's produced, or that is producing stimulation of the glucoreceptors that will stimulate the vagus to produce the muscle contraction. Bilateral vagotomy abolish hunger contraction but not the hunger sensation. If we cut the vagus nerve supplying the stomach on both sides, the hunger pangs will disappear. The hunger pangs will disappear, while the hunger sensation felt in the level of the hypothalamus will still persist. Here in this experiment, the subject swallow a balloon, and this balloon is going to measure the pressure changes inside the stomach, and the subject is going to press when there is feeling of hungry. So that is the sensation or the pressure changes appearing in the stomach, and at the same time the subject is going to press, giving the hunger pang sensation or the sensation of hunger. So stomach contraction accompany our feeling of hunger. In these days we are uh, hearing or seeing a lot of people doing something which is called the gastrectomy, or doing something which is a bariatric surgery to reduce the body weight by removing a part of the stomach and reducing the stomach size. What is the effects of gastrectomy? What are the effects of gastrectomy? Gastrectomy produce loss of the storage function of the stomach, loss of the storage function of the stomach. Number two, pernicious anemia due to the lack of intrinsic factor, lack of the intrinsic factor after removal of the parietal cells. Also, there is something called dumping syndrome, and this dumping syndrome is a distressing syndrome that sometimes occurs after meals. After meal, the subject is going to feel of abdominal discomfort due to sudden stretching of the duodenum after meal. The duodenum capacity is very low, so when you put large amount put meals, and these meals go directly from the stomach to the duodenum, the duodenum is going to produce abdominal discomfort as a result of its distension. Secondary hyperglycemia, passage of the food directly and rapid absorption of glucose followed by hypoglycemia. The rapid absorption of glucose from the duodenum will produce increase in the insulin, and this insulin will produce lowering of the blood glucose. So we have hyperglycemia will be followed by hypoglycemia. Also, there is weakness, dizziness, and sweating due to the hypoglycemia, hypovolemia, and hypotension. Hypoglycemia, hypovolemia, and hypotension will produce to weakness, dizziness, and sweating. Also, if we would like to add some of it, the bacterial overgrowth. One of the function of the acid coming from the stomach is to sterilize the intestine and keeping the intestine free of bacteria. Decreasing of the amount of acids passing from the stomach to the intestine will produce something called the small intestinal bacterial overgrowth, or SIBO, small intestinal bacterial overgrowth. The housekeeper of the gut. The housekeeper of the gut. The housekeeper of the gut is the migrating motor complex. The migrating motor complex is a specific type or a special type of motility that appears in the interdigestive period. In the interdigestive period means that after the stomach finishing its emptying and the process of food digestion and emptying of the stomach has been finished, another movement coming from the stomach called the migrating motor complex, and this is usually occur due to modification of the electrical and motor activity of the gastrointestinal smooth muscles, due to modification of the electrical and motor activity of the gastrointestinal smooth muscle. This migrating motor complex will start from the stomach until reaching to the distal ileum. And what is the function? It is to remove the non-digested remnant, or any secretions remaining in the stomach. Usually the empty stomach rests for 75 to 90 minutes, then 5 to 10 minutes there is intense contraction of the antrum with relaxed pylorus, allowing the migrating motor complex to remove the secretions, to remove the non-digested remnants, and then it will continue reaching to the duodenum, jejunum, and ileum. What is the function of this? It is cleaning of the stomach and intestine, preventing the fermentation of food, preventing the fermentation of food. The migrating motor complex are initiated by a hormone called motilin hormone. Motilin hormone. So when a meal is ingested, the secretion of motilin is suppressed, and this will produce inhibition of the migrating motor complex or stoppage of the migrating motor complex. The migrating motor complex occurs or initiated by motilin, and its function is to remove the remnant of food or the remnant of secretion to prevent the food fermentation, and putrefaction. Now we are moving to vomiting or the reflex expulsion of the gastric contents through the mouth. The reflex expulsion of the gastric contents through the mouth is known as the vomiting, and this usually appear due to stimulation of the vomiting center located in the medulla oblongata. Stimulation of the vomiting center located in the medulla oblongata is going to stimulate the 5th, 7th, 9th, 10th, and 12th cranial nerves. This means that trigeminal, facial, glossopharyngeal, vagus, and even the hypoglossal nerves, which are cranial nerves with some spinal nerves supplying the diaphragm, especially the phrenic nerve, and the muscles or the abdominal muscles. The spinal nerves supplying the diaphragm and abdominal muscles with these cranial nerves are going to work in a coordination to produce the expulsion of the gastric contents to the esophagus, to the pharynx, and then through the mouth. So what's happening with the stimulation of the vomiting center? There will be forced inspiration to move the diaphragm downward, and this will increase the intra-abdominal pressure. Also, we have closure of the glottis and elevation of the soft palate to prevent the aspiration of vomitus. We have changes here like happened during swallowing to prevent the aspiration of vomitus into the larynx and trachea. Relaxation of the body of the stomach and the lower esophageal sphincter. They are going to be relaxed in order to help the expulsion of the contents. Contraction of the abdominal wall, contraction of the abdominal wall to increase the intra-abdominal pressure. So with increase in the intra-abdominal pressure and relaxation of the wall of the stomach, relaxation of the lower esophageal sphincter, the food contents will be ejected towards the mouth. In certain situations, there is a pallor, excessive salivation, sweating, and antipersals also may appear from the small intestine. Sometimes, in certain situations, antipersals comes from the small intestine. There is something which is called nausea. Nausea is a manifestation which or a sign or a symptom that's usually become or appear before the vomiting, which is associated with pallor and excessive salivation, sweating, and in certain situations like intestinal obstruction, there is antipersals coming from the intestine pushing the food back to the stomach to initiate the process of vomiting. Usually, the antipersals coming from the small intestine leads to vomiting. The vomitus color is usually green. This means that it contains bile. This means that it's coming from the small intestine. Again, if the vomitus is green in color, means it contains bile, and this means that the presence of antipersals coming from the small intestine to the stomach to initiate the vomiting. Again, during vomiting, there is contraction of the diaphragm downwards, contraction of the abdominal wall muscles, relaxation of the wall of the stomach, relaxation of the lower esophageal sphincter as well as the upper esophageal sphincter, and closure of the glottis, approximation of the vocal cords, and contraction, elevation of the soft palate to prevent the aspiration of vomitus. This will be associated with increase in the intra-abdominal pressure to facilitate the process of the expulsion of the gastric contents towards the esophagus. Now we are moving to the causes of vomiting. Vomiting can be caused by multiple factors or multiple causes. Vomiting may be central due to stimulation of the vomiting center as in meningitis or increased intracranial tension. May be caused by drugs that can stimulate the chemoreceptor trigger zone in the medulla oblongata like apomorphine and digitalis. Also, it can be caused by certain chemical substance present in the blood as in pregnancy, uremia, increase in the urea in cases of renal failure, and in diabetic ketoacidosis. In these cases, there is a stimulation of the chemoreceptor trigger zone. Reflex vomiting. The second cause of vomiting may be reflex vomiting, and this vomiting is usually occur as a result of the conditioned reflexes like in psychic vomiting, which is initiated by specific stimuli like certain odors or certain specific visual stimuli or specific emotions. Another cause of reflex vomiting may be caused by unconditioned reflex due to irritation of the stomach, as in gastric irritation by toxins or bacteria or by hard food, peritonitis or inflammation of the peritoneum. Intestinal obstruction, usually there is no passage of the intestinal contents from the small intestine to the large intestine, as occurring in intussusception or intestinal gangrene. What's going on? There is no peristalsis, so the food will return back to the stomach by empty peristalsis, and the stomach try to produce expulsion of it by vomiting. Irritation of the posterior part of the tongue and oropharynx. Myocardial infarction. All these stimuli are working by discharging impulses to the vomiting center, and when they stimulate the vomiting center, the reflex vomiting will appear. Another cause of vomiting is the vestibular cause, which is usually caused by motion sickness, due to stimulation of the receptors located in the semicircular canal, which is the cresta. This asymmetrical discharge of the cresta can produce the vomiting due to stimulation of the parasympathetic centers located in the medulla oblongata. Here we are going to look for the function of vomiting and effects of vomiting. The function of vomiting is to remove the irritant, so it will provide rest and help to the stomach to get out or to get rid from the irritant or the toxins or the bacteria that's present in food. So it's considered as one of the mechanisms that helps the body to get rid of toxins and whatever irritant present in the stomach. But what are the effects of vomiting? Vomiting, usually if it is prolonged and continuous, it will produce dehydration due to the hypovolemia and the decrease in the blood volume. Loss of electrolytes, usually there is hypokalemia and hyponatremia. Metabolic alkalosis as a result of the loss of hydrogen and the formation or increase bicarbonate in the blood. In some cases, there is gastric rupture. There is Mallory-Weiss syndrome, which is bleeding due to erosion of the lower part of the esophagus. Aspiration of the hydrochloric acid, pepsin, and the gastric contents may produce pneumonia, and damage of teeth. These are the effects of prolonged or chronic vomiting. So vomiting will produce hypovolemia and dehydration, loss of electrolytes, mainly hyponatremia and hypokalemia, metabolic alkalosis due to increase in the bicarbonate formation and hydrogen loss, gastric rupture, aspiration of the vomitus and pneumonia, Mallory-Weiss syndrome, which means erosion of the lower end of the esophagus causing hematemesis or the vomiting of blood, and lastly damage of teeth by the acid coming from the stomach. And at the end, thank you and see you in the next lecture.